Good morning, everyone. Thanks so much for being here. If everybody could take a seat. I'm Lauren Berman. I'm the chair of the APSA Wellness Committee. I'm really excited to be here with Monica Lopez, former chair of
Hi.
Quality and Safety Committee. And we have a session today to discuss M&M and how to change the culture of M&M and focus on improvement and try to move away from the shame and blame that many of us grew up with, and some of us may still be experiencing. So very excited to introduce our panel. We have Casey Golden from Seattle Children's, who will be talking about the role of the APP in M&M and helping it become a more QI-driven M&M. We have Brian Kenny from Nationwide, who will be discussing their approach. And then Reto is actually going to set the stage in a minute. I wanted to just quickly, there is a poll that's on the Whova app, and many of you filled it out already. If you haven't, feel free to do it in real time. I took these questions from a survey that we did probably like close to 8 or 10 years ago now, through the Quality and Safety Committee, and I was curious to see, how the answers might have changed over time. And so the first question is, does any M&M conference exist at your hospital, and how has it impacted patient safety? And I realize the people answering this survey are obviously self-selected to be more interested in this topic, so we're probably going to differ from the membership at large. But the majority of you, it says here, do say is answer A. I see actually the C's are increasing. And then there's one do not exist, and then there's one that exists, but it has not improved patient safety. So we hope today will help change that. Do you participate? What we found when we did the APSA survey years ago is out of all the different kind of quality and safety related activities that exist in a hospital, M&M was by far the most common thing that surgeons participated, even if they didn't have formal roles or formal interest in quality and safety. So I think it's a really important opportunity to engage everyone in quality and safety. And most of you do say that, oops, let me go to the next one. Everyone here almost participates. A couple only when my complications are presented, and one actually that it isn't even available. And I think that's more common than we realize. The next one. My M&M is effective in changing practice and preventing similar future events. And it looks like for this one, many people agree. Just a few strongly agree. There's a lot are kind of on the fence. So I would love to move everyone into that A category. And then I think my M&M is focused on system improvement rather than blaming and critiquing individuals. This is a little more mixed. We have a lot who are kind of neutral on this topic, which we really need to change. There's a few that strongly agree and some that actually disagree. And then the role of the APP, that's what Casey's going to be here to discuss. Do APPs submit cases, present cases, or otherwise participate at all? We have a vast majority that say never. So Casey, we're so excited to hear from you, how you've done that at Seattle Children's. And with that, I want to turn it over to Reto, who's going to set the stage with a really great quote that I pulled out of his slides. Complication is inevitable, but suffering is optional. Thank you.
So just to set the stage, I think a reason, I think one question that we have to ask ourselves, why do we do M&M? And I think that's from the American College of Surgeons Quality Improvement website. So to critically evaluate patient care and to integrate available evidence to improve surgical practice safety. And I think we need to have the framework, and our panelists will talk more about that, on how to use standardized method for case selection and case discussion. And I think, having worked at multiple different institutions, that is done very differently from place to place. And I think if we standardize that as well, we might do better as systems, but also as individuals. And I think we need to get plans to address some of the complications and problems potentially to improve our process, our patient care, and quality of care. I think it has been a time-honored tradition in surgery, and I think for those who are getting into mid or late careers. I think we all talked about that, and we remember some of the M&M discussions that were done in a somewhat not constructive way. And so it's also mandated by the ACGME Resident Review Committee to actually do that and to have QA programs to teach our learners on how to improve and how to discuss about these difficult cases sometimes. And again, it's an ABS MOC criteria that you can get your MOC like hours in, and it counts. And I think that's maybe not as important as all the rest of what's on my slide. So I think I want to touch briefly about complications and the surgeon and what it like resonates with us. So I think one important thing is that only non-operative surgeons do not have complications, and sometimes even the non-operative surgeons have complications when you should have done an operation. But I think we all face that, and I want to echo the discussion we had a couple of days ago in one of the sessions about how we deal with complications, and the ones who were there, I think it was very powerful, and I think I'll take that back home with me. I think we're expected to be accountable, decisive, and we aim for perfection, and that has been instilled in us during our whole training, and I think it's hard to deviate from that, and I think it shakes us, our confidence, our decisiveness, our perseverance, and potentially our reputation and our person. And I think emotionally it's very hard to deal with our own complications, and I think that's where M&M should be more supportive, and some places do it well, and I think we need to strive for that. I think the environment and the culture should also be supportive, and I think that's, in my mind, key. A couple of years ago, we looked at how people deal with complications in the literature, and we came up, Howle, I want to give him credit for that, came up with that title, as complications are inevitable, but suffering is optional. And we describe in a paper that you have the reference a little small down there, but it's free access in the European Journal of Pediatric Surgery, to create that framework of supportive approaches to dealing with complications. So we need to be accountable and supportive. We need to normalize the discussion. I think that's very important, that for our patients and for ourselves. I think one important question that I try to ask my residents, like every time something happens, I ask myself, what would I do differently next time? Can we learn from it? Can we be constructive about that learning process? And it needs to be quality improvement oriented. And I think it needs to be done with a culture of safety where we support each other in it. And then if things are hard, I think most of our institutions have a peer support process and a team, but APSA also has one, and I hope you all know where to get that on the website. Thank you.
Thanks, Rito. Well, thanks, Lauren, for the opportunity to talk about our program in Columbus and how we have focused on system problems to try to avoid the blame game a little bit. Of course, every complication has elements that are related to the individual and elements that are related to the system. And so by focusing on the system, I hope I can convince you that while we don't want to forget about the individual issues, and those need to be dealt with, that's better dealt with by the chief of your department or by somebody else if you have someone who's acting in a way that's not appropriate. But focusing on the system issues gets you a little bit away from that. So I'm going to try to explain a little bit about how we do that and the mechanism. I think that it's also important because these are more durable changes when you actually quantify and then change your system. So this is a very busy slide, obviously, but it's looking at the template that's filled out for every one of our M&Ms, and we have a categorization of, let's see there, so a categorization of the level of severity, so it might be a near miss or it might be, a terrible outcome. We have a characterization of preventability. And then we look at the type of error, whether it was a misdiagnosis or a delay in diagnosis, the sort of thing that's pretty traditional in categorization. But then this is the focus of the central portion of this, is the individual failure versus the system failure. And you can see there are different subcategories of these things. And finally, that results in action items, because this is where the QI happens, is really with the action items and actually changing your system. So when we look at the systems, a lot of these areas do overlap, I'll admit that, but we try to break them down a little bit. The sort of subcategories are, I think, less important than the major categories. You can see that the structure is important, whether you have the resources, whether you have mechanisms to work with each other. Culture is very important, as I think Rito mentioned. The process is important, whether you have good checks on your process. And then policy and procedure. We all have policies and procedures, but sometimes they're informal or they're just not usable or understandable. And of course, your environment's important too. So we presented some of this material 2 years ago at this conference, and we talked about how health information technology has helped to augment our QI-directed morbidity and mortality conference. So I'll review briefly some of that information. So we looked at about 7 years of data, and you could see that we have M&M every week because we have so many problematic cases, I guess. But of course, there are weeks that we miss, but 3 or 4 times a month we'll have M&M. And so we reviewed well over 1,000 cases in that period of time, and just over 10% of those we found some system failures in reviewing those cases. So it's not every case, but you know, a good 10% of and a number of system failures to work on. And looking at a Pareto chart, I think is interesting, because 80% of these failures are in these top 5 categories. And you know, if you look at these are the subcategories, but I'll give you the major categories as we look at these. But lacking or informal has to do with policy and protocol. So the most common thing is you just don't even have a policy or protocol around the issue that happened. And so that's a fix where you have to look at the literature and create a protocol. Secondly, collaboration mechanisms. So we have this in trauma, I think, very well worked out. So how we collaborate with our ED and, you know, with our radiology, that's, you know, pretty smooth in all of our hospitals, I'm sure. But in some areas, you know, the collaboration is not that smooth. So we have to work on developing better collaboration mechanism. Inadequate checks is in the area of process, and so we may have a process. It may not be that formal, but we don't have a check on, you know, when that process is not being followed properly. Non-collaboration is really a cultural issue. So if you've got, you know, 2 groups that maybe don't get along that well, maybe there's something between GI and general surgery when it comes to choledocholithiasis. I don't know if that's a problem at your hospital, but, you know, people may not collaborate well on a particular issue, and so that's a cultural issue that has to be worked out. So what we looked at with this paper was particularly developing these open action items, which is down here in this bottom. I don't know if my pointer is working, but you can see that month by month we had many open action items at a certain point. And we worked very hard to get those items closed, because that's where the real QI happens, when you open up an item and then you know, resolve it. And so now we're doing, you know, better in terms of closing these items quickly. So the last thing I'll leave you with is just a couple of thoughts. And one is that you know, all these issues that develop in our patients have a context. It's not you know, so they don't happen in a vacuum. There's usually a variety of causes, or at least influences, to why something might go wrong with a patient or might not be the best practice. We're always looking for a single root cause at M&M, and people focus on, you know, this was it. And really, the Swiss cheese model is a way we need to look at it as well, because that helps us to find other things. I don't know, I don't have a picture of it, but you probably all remember seeing this multiple slices of Swiss cheese and an arrow going through the holes. And, you know, these problems are happening all the time, but it's only the one that gets through all the holes that really ends in patient harm or a patient issue. But each of these slices represents, a factor that needs to be considered, and that's kind of what the system program makes you look at. It opens up possibilities to improve in multiple areas in your hospital, be it nursing, radiology, other areas. And it leads to system improvements that are really more durable in your system and thus have a wider impact. So I'll look forward to any questions on it. And thank you for listening.
Thank you for the opportunity to speak. I'm Casey Golden, and I'm going to speak on Seattle Children's hospital-wide standardized M&M and our QI triad. So our approach to M&M is a product of a current state assessment done in 2018 due to a serious safety event that went unnoticed. And this current state assessment was led by our patient safety medical director with the Children's Surgery Verification Program Manager, risk management, executive sponsorship, and pediatric surgeon Dr. Adam Golden, who apologizes for not being able to be here today, but I do work with him on this project, and we are not related, so we both have the last name Golden, but we spell them differently. This group found variable M&Ms across divisions with varied documentation styles, as noted in this messy binder photo. And there are various case selection and facilitation. There were some gaps in the confidentiality protections and a varied use of classification systems. So with their key driver diagram, they created a global aim to reduce preventable harm through improved learning, escalation, and systemic change from case analysis. The QI triad and the hospital-wide standard classification system were key to implementing their change ideas. In 2019, I joined Seattle Children's Hospital, and then we implemented the QI triad structure: a surgeon, an informatics specialist, and advanced practice provider, or APP. I became the first APP quality liaison at our hospital. This is a 0.1 FTE, which is about 4 hours a week to focus on the work. The APP reviews the records, validates the safety events, and records them with an initial classification. The informatics specialist provides us with data to improve our capture of safety events with a goal of 100%. The surgeon provides, the clinical conference triage and expertise so that the most productive cases are taken to M&M with a focus on educational insights and opportunities for improvement. So the QI triad now provides a standardized structure for event capture and documentation, and we report up to our surgical quality leadership and our multidisciplinary performance improvement patient safety committee. This structure has now been implemented in our hospital in over 11 divisions. In order to audit benchmarking data, a surgical quality and safety core measures dashboard was created, which you see here. I apologize for the fine print, but I do want to point out the scope of the dashboard. There are over 30 tiles that link to live data, and the columns are categorized by the Institute of Medicine's 6 domains of healthcare quality. It's an incredible product and has a wide extent of data, but I do want to point out the green and the red can provide clues to whether or not we're meeting our goals, and also wanted to note that our actual live data is not represented in this tile, and as Dr. Steve Lee, our division chief, said, if it were Seattle Children's, it would all be green, right? And then, so the link dashboards, if you click on a tile, it links to another dashboard, which we use Tableau which is a software company. And this aids in our goal of 100% safety capture. So every month, we run a report of our mortality within 30 days of a procedure, our readmissions within 30 days, our returns to OR within 30 days, our admissions to the ICU within 48 hours of a surgery, our SSIs, and oh, it's funny. If you click out of it, then you can't click back. Sorry, if you're wondering what I'm doing. And these and other data are also used to support QI efforts. Additionally, all of our APPs and surgeons provide active surveillance with their patient care, and they share events with our QI triad and their handoffs and their safety events and safety stories. And we have a direct M&M email address that I monitor. So another key driver to reduce our M&M variability was through the use of a hospital-wide simple classification system. This provides a common language across our groups. And it was established because first it indicates level of harm. Is it a mortality, a morbidity, or a near miss? And then it focuses the discussion on opportunities for improvement instead of shame and blame. To achieve this key driver, our intervention was templated slides, the centralized registry of events, and a clear path of escalation. This is our slide template, and it summarizes the common language. So after our surgery fellows present the patient hospital course, we use these questions to drive our group discussion with attendings, fellows, residents, APPs, and sometimes nurses or other groups are invited. Was the event a mortality, a morbidity, or a near miss? Is this an unanticipated outcome? Are there opportunities for improvement? Was the outcome related to the patient's disease, a system failure, or a technique or diagnostic decision-making? Are there action items based on the review of this case? Were there equity concerns? And is there a recommendation for additional review or feedback needed to the referring hospital? And then our M&M registry was created within our REDCap. So this provides the patient demographics, the QI discussion, the procedure name, surgeon, and procedure date. So then we can later organize and pull records based on this information. It then includes our common language, and mortality, and morbidity, or near miss, where there are opportunities for improvement. We can track action items with a checkbox if it were completed. Then we also use the HPI taxonomy of system failure modes, and we can track them here. And we also track our children's surgery verification events. Not pictured in my screenshots are dates of each review that happened, the attendees at the M&M meeting, and then there's also a link to our job aid on escalations. And then the APP is key to inputting this and updating the data in the REDCap. And we use REDCap to track our reviews that are additional reviews that are needed, or if it needs to go to M&M, and if action items were completed. This is our escalation pathway. So it starts with the QI triad review. The black arrows indicate possible next steps. So we could send it to another service like radiology, or we could do our own division, M&M. We could send to patient safety, or we could do a joint service review because we have quarterly multidisciplinary meetings with the NICU, PICU, GI, and ED. And then we could also refer or send the case to the referring institution if we thought there was a possible opportunity. The orange arrows indicate that a QI project was implemented based on these reviews, and then those are presented at our PIPS committee. And additionally, we report all our mortalities out to the PIPS committee annually. So my role as an APP quality liaison helps support the event capture and adds coordination and collaboration. The algorithms in our dashboard are sensitive, but they're not specific, so I do need to spend time validating that an actual unanticipated safety event occurred with my chart reviews. Then I seek feedback from the involved surgeons on which cases need to be presented at M&M, and I share M&M case lists with our fellows and attendings. And the APPs, and I present quality metrics, including trends and line lists, denominator data, mortalities, unanticipated review returns, and readmissions and SSIs. And this is done about quarterly at the beginning of our M&M meeting. And our APP QI attends and documents the discussion and categorization in the REDCap record. We have collaborated with our division chief, our fellowship program director to make sure we're still meeting our ACGME guide requirements, and our NISQIP leaders. We also work closely with our NICU, PICU, ECMO committee, anesthesia, patient safety, and our nurse educators on our joint M&M reviews. We also partner with our clinical standard work, which is Seattle Children's Evidence-Based Clinical Care Guidelines. And we also work closely with our children's surgery verification program manager and help provide timely, thorough, and accessible documentation. So in summary, we have a standardized M&M and a centralized database that focuses on level of harm, on action items completed, and it includes our escalation pathway so that our reviews are visible to leadership and to our quality oversight committees. The QI APP is now a central part of surgical quality. We provide passive surveillance, which hopefully removes biases, and provide a contact for active surveillance. We are increasing communication and breaking down silos. We're improving our capture and follow-up, and we're providing a stable working relationship and an environment of frequent changeover of fellows and residents. We have increased utilization of our APP skill set, and we've empowered the APPs to provide input on safety reviews. This creates a quality web, and with the QI triad, hopefully the M&M process is positioned to drive optimization across the hospital. Thank you.
Thank you so much, Casey and Brian. I just learned so much from listening, and we have a good amount of time for Q&A, and I have a few questions for both of you, but if anyone in the audience has questions, feel free to come up to the mic. So as I was sitting and kind of reflecting and listening, I think both Seattle Children's and Nationwide are very resource-rich hospitals, and I think it's great to be in an environment like that, but I think a lot of people are in a place where maybe there isn't even a formal M&M. So maybe some thoughts about like, how do you even get started, right? If you're in a hospital that doesn't have like a robust improvement team. Casey, I was wondering too, you mentioned about APP empowerment. How does that dynamic play out if a complication is brought up and maybe the surgeon doesn't feel like it needs to be presented, like how do you kind of navigate that dynamic? So maybe each of you guys could talk a little bit about those thoughts, and then we have lots of questions, so we'll get going on those.
So I'll address, thank you for the question, the APP empowerment. So we also request feedback from the fellows that were involved in the case, and if they want to present it because they think it would be interesting for their education. So it's not coming from a place of we're presenting this because we think, one person did something bad. We're presenting it because we think we could learn something from it. And then having the QI surgeon champion and reviewing those cases with them also provides another reason to bring it to conference. And then we also have that M&M email address so that another involved party could say, I'd like to talk about this more at our M&M conference.
Yeah, I was just going to mention that when you look at that Pareto chart, you see it's going to be different for every hospital. And I think there are definitely hospitals where the resources is going to be one of the more important issues. Yes, we are in a very resource-rich environment in Columbus, so I'm very happy to have that. And that's why we need to work on other things like, collaborative mechanisms and that sort of thing. The other thing I was going to mention is that when we, this is a development over many, many years. So really at the beginning, though, it was very, very simple. It was all on paper. I think Mehul was at that time as we were getting that started, and he was probably very integral in getting it started. But you pull together what resources you have, and that changes a little bit over time. Certainly having the fellows has been great because they identify most of the cases. We get some of the cases that come through because they're identified by the CSV process, where we have infections, et cetera, that may not show up on the fellows' radar, but are still important, need to be reviewed. So we have some reports that come in. As far as pulling together resources to do this kind of work, we use our administrative people in different roles to help, put together the presentation, to help to gather the data. And then we have a nurse who helps to input data into our database. So it involves a number of people you have to pull from wherever you can to get it, and that's evolved a little bit over time.
Matt Santori from Atlanta. Thanks very much. I think this is, well, you guys have developed Casey in Seattle as aspirational. We struggle with kind of standardizing M&M across service lines. I think it's a little bit easier for general surgery, pediatric surgery to standardize it. The other thing that we struggle with is resources. You've been able to allocate a 0.1 APP FTE. I guess my two questions are, how do you convince the administration that this is worthwhile? Because it's a big resource and, money's tight. The other thing is, have you been able to show improvement with your NSQIP data or your morbidity and mortality over time?
Thank you. So first, for the question about resource allocation, I luckily didn't have to do any of the budgeting because that is not my background. My background is I have a master's in public health and worked in Hawaii with the trauma program there. So I came into Seattle Children's with a desire to learn about the Children's Surgery Verification Program because it was similar to the trauma program. And then Dr. Golden we were at morning rounds, and he was talking about children's surgery verification, and I said I was interested. So that's kind of the history of how this got started, was just, and then he also, saw the importance of the APP, and we are a very large group at Seattle Children's. We have a very large APP presence. So we wanted to, he recognized the importance of involving us in this work. But I can definitely put you in contact with Adam and our APP chief who helped get the funding. And then the second question, I'm sorry, I'm forgetting it now.
You've implemented things, but have you been able to show improvement in your outcomes? And that is another area that we'd like to pursue. Now we have all of this data, and I really like the way you represented it with the Pareto chart, but those are our goals and something we want to look at. But we have, we are seeing that we're not really seeing any trends upwards when we're looking at our trend data. Thanks very much. Great presentations.
If I can just add to that, one thing I'd didn't really talk about was the leadership that's involved in this. It takes very strong leadership. I am just middle management at our hospital, so I tried to implement this, at the beginning, and it really didn't get traction until Gail Besner got interested in it and felt that it was big, and then she was, able to change the way we did business in terms of our M&M, and then from there, the CSV process was also very helpful because it essentially mandates doing something like this in every division. So our next challenge was trying to spread it to these other divisions, and the first question they always asked was, well, where's the resources? How are we going to get the resources to do this? But our surgeon in chief then said to all the divisions, you have to do this, and you have to find resources to do this. And as I said, you start off by just having administrative people kind of help you get it going, and then eventually, if you can get an APP, that's great. But we don't have that. We have some nurses involved in some parts of the process, but not anyone overlooking the whole process. And the last thing I'll just say is it's very hard to demonstrate outcome improvements, but definitely we're showing a lot of process improvements, which we believe leads to better outcomes.
Mehul, Chicago. Thank you guys for this panel. It was really insightful, and I think that there's a lot of lessons learned. I just want to echo what Dr. Kenny just mentioned, which is every hospital has an aspirational goal, every children's hospital, to be something, whether it be a level 1 verified children's surgery verified center, whether it be a level 1 trauma center, whether it be whatnot. And this is where we can use these standards to actually get those resources. To say, well, gosh, we really want to be able to hang that plaque or compete or recognize our institution, then we need to mobilize the resources to do what you've described. The IT lift is huge. It took us over a year to build at our institution, with a lot of person hours going into it on the IT infrastructure side. The weekly or daily or monthly operational execution of case review is a heavy lift. And if you put it all on the one FTE, that is maybe your children's surgery program manager or whatnot, they will burn out. You will lose them. The turnover is quite high. No one's written that study if anybody's interested, but I would love to see what the turnover rate is. I think the average lifespan of a CSV program manager in that role is, if you're lucky, 2 or 3 years. And so these are very real obstacles that we have to overcome as societies, as passionate care providers, and we have to make that case to our leadership to get those resources. I do have a question. Okay, so when I go home today, I've got a problem. I've got a problem where our legal team is asking me for my REDCap data. And we have an Illinois Medical Protection Act for quality and safety work. Yet, if you use a database for anything other than internal quality improvement, which I do, guys, I use it for my CSV verification when they come do my site visits every 3 years, then there's a precedent that is discoverable. Has anyone ever asked you guys or anyone in the audience for you to disclose this information? And if so, do we have any societal or guidance on how to respond to that? Because I really don't want to turn it over. I think it's majorly detrimental to the work that we're trying to accomplish here if we have to start turning these things over. So I got to go home and answer this question. I need any advice you guys can have.
This is my nightmare in doing all this work over the last 10 or 15 years, is that this data is going to be collected and then it's going to be used against the surgeons. I mean, this literally wakes me up at night to say, why did you do all this and now I'm out of a job or something like that. And it's just, and there's that, there are knocks on the door from administration. There are knocks on the door from other people inside the hospital asking to review some of this stuff. And I do everything I can to resist it, but at the end of the day, when those knocks come from your administration, you have to show it. Now, as far as outside your hospital, all of this stuff is protected in Ohio. So I guess I don't have an answer to your outside the hospital question.
Hale Wills, Baylor Scott and White, Temple, Texas. In my previous role as a trauma director in Rhode Island, I had to go through this discussion with our general counsel, the American College of Surgeons, and our CMO every 3 years, because the ACS wanted lots of detail in all of our reports. Discovery in that state, any mention in any email opened the whole door to discovery for the whole peer review process. So on a 3-year cycle, I said, okay, I want to see the whole legal statute. I want the general counsel to write a new, freshly dated letter. Like, you have to march through all those things every time and just make sure everyone realizes you may not want what you're asking, because you have, like Rhode Island, you had access to the metadata of what your, like, potentially even your keystroke files of what you put in that note that then you erase and then you put back in the note. And it's like some of that data is somewhere on someone's server and potentially discoverable. So sometimes the attorneys don't realize that. They think you're withholding something of great value to them for protection, but we have a tail that lasts until the age of majority plus some time. I really don't want that exposure if I don't need it. But it's like you just have to bring the top dog of each thing to the table, say this is why we can't do that. Everyone eventually will say, sure, I get it. But it can be a bit onerous, but you want to be really protective of that data.
Eric Rellinger from the University.
Can I just make a response to, I'm sorry, email is discoverable and it's dangerous, as Hale brings up. And so we have built a system that is secure enough that we can make communications within the hospital, within the systems, actually in the cloud, but it's all non-discoverable. So that's the idea, is to have all of your data within a system that so that you're not using emails. Now, we are currently still using some email, but we're working to stop using email for any of those communications, because, as you point out, it opens up the door to all kinds of trouble.
Thank you. So Eric Rellinger, University of Kentucky. I trained at Cincinnati Children's, which is a pretty resource-rich environment, and then I started my practice at the University of Kentucky, where, you know, the pediatric surgery department was part of a larger department of surgery. So historically, M&M, you know, is done with the Department of General Surgery, and what I realized was I was talking about neonatal cases with, you know, an adult colorectal surgeon who may have very little insight into the disease processes that I share. So one benefit of COVID is the world became a little bit smaller. So I was very fortunate to get to start to create a cross-institutional M&M where Cincinnati allowed us to start presenting our M&Ms to them, which was really valuable at an early stage of career where you're a young surgeon, you're in a less resource-rich environment, and you get to present your hard cases to you go from a group of 4 or 5 to a group of 30 experienced people, and some of which have very niche practices. And that has a lot of value. So the bidirectionality of that both gives you confidence early in your career as far that you're making the right decisions. And the other thing that it opens your eyes to is that it also helps you realize that people spill water everywhere. So like seeing other people who are accomplished, you know, have similar struggles that has been pointed out has been really helpful to a lot of the junior partners. So as the world has changed over the last 3 or 4 years, I realize there's regulations, I realize there's legality to this, but I also think there's real opportunity to be able to standardize care regionally as opposed to just within the silo of your hospital. So I would just love to hear people's perspectives. Sounds like we got to refine the process. The action arm we don't really have, but just creating the forum where people can continue to grow and develop and feel supported is really helpful for folks trying to grow practices in lower resourced environments.
Thank you.
Yeah, thank you for saying that. I think there's so much to unpack in what you just said. I think a lot of us might practice in small groups and may not have a lot of peers. That also might be relevant in subspecialties. Some people have mentioned the difficulty in permeating across the subspecialties. So I think that model of finding a larger group to work with. And I think the other thing I just wanted to emphasize from what you just said is when you're in M&M, and you hear a complication being presented and that has happened to you, just to say that and to normalize it. And the M&M is not necessarily the venue, to provide peer support, but just to, I've been, especially when we think about the opposite, like the big M&Ms that might happen in Cincinnati or that we experienced as general surgery residents. I still remember one of my co-chiefs, there was a thyroidectomy done prophylactically and the patient died from a neck hematoma, and my co-chief was presenting it and just absolutely got raked over the coals by our chair, and it was horrific to watch. And I don't know if he's recovered from that to this day. Whereas, if someone had said, like, this happens and it's horrible and how can we improve our system so it doesn't happen again, that would have changed everything. So thank you for saying that. I just wanted to amplify that.
I want just echo it. Sorry, I think I would ask also Cincinnati, because I think it would be interesting for all of us to know about that and see if we can replicate at other sites or write a perspective in the journal. And I know Dr. Holcomb is there, so he might be open to that, like a perspective about how you do M&M at smaller groups and reach out to your bigger site. So I don't know if you want to describe it. It would be actually great for us to know.
I'd love to do that. Thank you, guys.
Steve Stilianos from Rutgers, and thanks to the panelists. For us to have a session on re-envisioning M&M means that the previous versions of M&M were bad. I can confirm that. And Lauren just used the term raked over the coals. There's a ton of expressions we can use, but the themes were not that the chairs at that time were just the cruelest, masochistic individuals on the planet. It was, and there's an analogy in sports, is you're supposed to feel this pain. You're supposed to feel this pain so badly that you will never have that happen again. You can see that that's a flawed strategy, but that's what the strategy was, because you were humiliated in front of your entire department, and it was to feel that pain. We didn't have terms like system engineers and infrastructure and policy and systems. We didn't know that. We just knew pain. Now, there is something, though, to be said, and that's why I love the panelists to comment on. Individual accountability still matters. You can't throw this all 95% on the system failed me. What we need to do, though, is to give individuals the tools to succeed. And that's why what you just presented makes so much sense. It's really to arm ourselves with the tools to succeed so we don't have to feel the pain as often and as publicly as we do. So thank you very much. Very important work, and I'll sit down now.
I know we're at time, so if people need to go to another session, please feel free to get up and go. But we'll just have these last two questions and a very quick wrap up.
I will just comment on what Steve said. I think that the individual part never goes away. So that's what I was trying to say up there, is that there's always the individual and the system, but focusing on the system is what we can improve on with QI. Focus on the individual. I mean, people in our room, even though we've got a big room, a lot of surgeons, they all know whose case that was, and everybody knows what happened, and that person still feels that to different extent, and then they show that to different extent. I mean, I feel these things terribly, and I crack, when I'm presenting or something happens to one of my patients. Other people are very steeled against it, and they may not show it, but people know who it is, and they know who it is. So you don't escape the individual, and it's important, but anyway, sorry.
Mohammed Imran, Corpus Christi. So we have a kind of a similar situation where we're doing cross-institutional work because of our fellowship. So we have two centers, UTMB and Driscoll Children's Hospital, and we do the weekly M&Ms across that, and that's been great. Biggest challenge I have, and which is my question, is there are certain people who have been affected by this past idea so much, or have been working in isolation for so long that they have an insecurity about being a part of this. and it creates a dynamic where not only are they afraid of not coming to the M&M, so they're not learning anything, but then those M&Ms are still being presented, and now the person is not there to defend themselves or talk about what happened or learn from it. So do y'all have any thoughts about how to try to pull in an individual or people who are suffering from those kind of past traumas back into the fold to try to get them incorporated into M&Ms?
I think it's the culture of safety that has to prevail, and I think to be inclusive. I think, again, scars take time to soften, but I think it's important to include them as best as you can. I think it's harder not to be present when your complication is presented rather than actually be present, own it, but be constructive about it. And I think as a learner, you don't want to have like a resident present something that they were partially involved in the decision-making process, because that's even harder. I think all of us have stood up there and had to defend decisions that we didn't make, and I think that's probably part of the pain that Dr. Stylianos described as well. And I think I would see to include that like culture of safety and people feeling that, yes, again, complications happen, but we can work to learn from them, and the benefit of the learning out like is stronger than the harm that you might feel. And I think that will, in my experience, it takes years.
One other point is be universal with your presentation. So don't let your chief select which ones they want to do. But I mean, everything gets presented. We have a complete presentation for most of these, but then there's also a section that are brief, particularly our appendectomies. You know, they come back with an abscess, they get a brief presentation, not much discussion around it because we've got so much process and protocol around it. But everybody's name ends up on that list, you know, sometime in the month if we're doing it every week.
Nigel Hall, Southampton. Thanks. This was a great initiative and presentation. Thank you all. So some of what I was going to ask about has been answered in the last couple of comments. Is around how we go about protecting the individual and really shifting away from blame to quality assurance. A couple of things we've done. So we've stopped calling it M&M. So M&M's got this stigma with it. Okay. So we call it PSQAM, Pediatric Surgery Quality Assurance Meeting. Okay. And just that one shift has really changed how people come to the meeting and they're really focused. It's on quality assurance, it's on learning. And the other things around how we have the discussion. You know, we don't sit like this in a classroom, we sit in a big circle. And just these kind of psychological things really change how people interact with each other, and I think have got real power in terms of how the discussion actually flows. So my question was going to be, does anyone take that further? Has anyone got a framework of how the discussion should happen to really try and go away from this culture of blame and humiliation that Steve was talking about? You know, we've heard lots about systems that no doubt make the process better, allow us to get better data in, potentially learn at a system level. Has anyone got any ideas for how to actually make sure the discussion runs in such a way that that blame just can't ever happen, it can't be seen, and that the shift really does just come away from humiliation and blame?
You know, I think that the templates that were presented here help, and even if you don't have, you know, a 0.1 APP or, you know, a QI specialist sitting in your M&M, if you go through those questions of like, is this a known complication? Was it preventable? What could we do differently to prevent it? It kind of helps to ask those questions versus just the free form, like, well, what were you thinking when you used that suture, or you didn't take the patient to the OR at that time? And then I think it's really about who's moderating the M&M. So if any of the conversation even starts to go down that hole, you immediately stop and redirect. So, but I think, you know, I think Monica was going to do a quick wrap up now that we're a little bit past time. But thank you for that question.
Yeah, no, I agree. I agree the structured templates definitely help. Just stick to it. Should be able to be a productive discussion. But anyway, we are beyond time, and I thank all of our panelists and each of you for being here. I'd like to invite you all to visit our APSA Quality and Safety Toolkit. You will find there, this is a way to continue exploring the content that was shared here and content on many other pediatric surgical conditions. I think we have information, more than 30 conditions now, where you guys can figure out what's being done elsewhere, how you can adapt this content to your own setting. So we will make sure that this information is posted there as well. And I invite you to visit and engage with it. Thank you.